and good to have you with us in this edition of the Urban Debate. Tonight, we again start off with all things COVID and get you the latest updates from across the world. We're going to talk about the new COVID strains, the spread of infection. We're going to talk about the new travel restrictions in many parts of the world and in our own country, and also the latest as far as the race for vaccines are concerned. Now, of course, the first new thing that has emerged is United Kingdom saying that they've identified another new COVID strain. This one is the second mutant strain reportedly has come into United Kingdom from South Africa. Further investigation, of course, is underway. But two new cases of the second mutated strain have been detected in UK. And according to the UK Health Secretary, this is even more contagious than the first new strain. Now, remember, the point about these new strains are we don't know if they are deadly or in any aspect, but we definitely know that they are more contagious, that they spread easier, that they spread faster. And which is why it's become a big problem, not just in United Kingdom, but of course, in today's day and age, when people begin to travel from one part of the world to the other, then it's a problem for the entire world. Right now, UK has called for immediate quarantining for all the returnees from South Africa. In fact, in our own country, in many of the states now, we've begun to step up restrictions and quarantining rules for those returning not just from UK, but Middle East, Europe, and South Africa as well. Germany, Switzerland, and UK have imposed restrictions on South Africa travel. So before we move on to the other aspects, let me first bring in an expert who is joining us, Dr. Andrew Friedman, Associate Professor for Infectious Diseases at the Cardiff University, is joining us from United Kingdom. Dr. Friedman, thank you for being with us. If you can help our viewers understand just how serious is this new COVID strain, how much more contagious is it from the one we know of?
So good evening. So the strain from South Africa, we know very little about at the moment. We've only had 2 cases identified in this country, but the word is that it is more contagious than the new strain that we've seen in the UK that has been spreading rapidly over the past few weeks.
Why is it that we are seeing now these new strains that have emerged which are more contagious, Dr. Friedman? Of course, these are not the only ones. There are many variants which are already out there across the world. But is there a specific trend we are looking at?
No, well, absolutely. The viruses, and particularly RNA viruses like this one, they do mutate with time. That's normal. And what happens is you tend to get selection of variants, new strains that have certain improved biological properties as far as the virus is concerned. And so being able to transmit more readily is one of those. And so this strain has really been selected and it's becoming more prevalent because it does transmit more readily. And it's been shown that the mutations in the spike protein, the bit of the virus that latches on, that binds to human cells, that's where most of these mutations are. And that confers an advantage in that the virus can bind more readily to those human cells. It binds more avidly, and that seems to translate into more transmission, more infectiousness.
So what should the ideal response be? Of course, UK has brought in strict rules now, and lockdown in many parts. In our own country, we're also looking at bringing about night curfew at least so that less people, gather during festival season. What would your advice be as we find out more about these new strains?
Yeah, well, obviously, the virus spreads by human-to-human contact. So the more measures that are taken to reduce contact, particularly indoors where the virus we know spreads more readily, then the better we're able to control the spread of the infection, particularly these more infectious strains. And certainly in the UK, we've been introducing much stricter measures across different parts of the country, according to where the prevalence is greatest.
Is there any evidence to suggest right now that they could be deadlier or more potent than the original form?
No, there's no evidence at all at the moment that it causes any more severe disease or any greater mortality. The main difference does seem to be the infectivity.
With these mutations, Dr. Friedman, generally do the same vaccines work, or is that something that we will have to investigate separately?
Yeah, there's no evidence, and there's every likelihood that the existing vaccines will work against this mutant strain and other strains. That is something that is being looked at in the laboratory to see whether people who've been vaccinated, the antibodies that they produce, whether they're able to neutralize this strain of the virus. But there's every reason to think that they will work, because the immune response that the vaccines stimulate act against various different regions of the spike protein, not just the ones where these mutations have occurred.
All right. Now, I just wanted to ask you a couple of larger questions as well. In the light of what we've seen, new strains emerging in South Africa, in United Kingdom, and perhaps other parts of the world as well, how do we prepare ourselves as we get into 2021? What should be the top two things that people keep in mind as we prepare for New Year?
Well, the advice is always the same, obviously, to reduce mixing, particularly indoors. As I've said, hand washing, regular hand washing, wearing of face masks are very important. And those are the measures that will prevent spread. If you reduce human-to-human contact, then you'll reduce spread of the infection. But it's obviously important that the infection is monitored very carefully. And so additional measures can be introduced where they're required and when they're required. It's important to get ahead of it and introduce measures before the infection has got out of control.
Dr. Andrew Friedman, thank you so much for joining us, with your expert views and comments and sharing those insights. Really appreciate you giving us your time.
It's a pleasure.
Thank you. Well, let me also tell our viewers that back home itself, we are trying to now closely track people who've returned not just from United Kingdom, but other parts of the world as well, and could be perhaps carrying this new variant. But in Delhi, 11 travelers from UK have tested COVID positive already. Now their samples have been sent to the National Institute of Virology in Pune. In Kolkata, 2 travelers had tested positive. In Chennai, it was 1 traveler who tested positive. As well, we've got now news coming in from other parts of the country as well. So in Amritsar, 8 travelers from UK tested positive. Again, for all of these places, once you have tested positive, and if you're on your way back from UK, your samples are further sent to NIV in Pune. That's the institute that's testing specifically for the new COVID strain. 4 travelers from UK in Ahmedabad have also tested positive, 1 in Ludhiana. And then in Maharashtra, in the city of Nagpur, also 1 traveler from UK tested positive. In Maharashtra, in fact, government has started to now go back and see everybody who came back in the last 1 month. And they're getting in touch with those travelers for more information, because now more and more cases are emerging from various parts of the country. 11 travelers from UK tested positive in Goa as well. That's the other big number that has come in. In fact, 2 of these returnees, and I really don't understand why people do this, but 2 passengers who came back, tested positive, actually left the facility and headed to their own home states and hometowns with zero respect for other people and their health, zero concern for anything else. Despite the fact that now these rules have been put in place and anybody who lands in our country from United Kingdom is informed about these rules. But that's how it is with some people in this world. Now, let's talk about this. And let me say good evening to our other 2 panelists who are joining us for this special conversation. Dr. Rajesh Parikh, Director for Medical Research at Jaslok Hospital, joins us this evening. He's also authored a book called The Coronavirus Book. And Professor Sudhir Krishna, National Center for Biological Sciences and Professor at IIT Goa. Always good to have him with us. Professor Krishna, I would like to begin with you. With a very simple question. When we saw in the first part of COVID spread, what we saw in March, the first few weeks of March, where we had just begun to realize that people had started to come in our country, and then we went, we brought in these restrictions, and then we tried tracking them down and testing them. We didn't even have the enough appropriate test kits. Is that a problem we'll face again, Professor Krishna? Because even now, I'm told there are only 2 labs in the country that can test for this variant.
Right. Thanks for having me over. I can't predict the future, but I can tell you what I think is reasonable. The first is that the epidemic is played out here very differently. You had a guest from the UK on the show before. But if you look at the way it's played out in the UK, and I'm not just talking about deaths per million, but the shape of the epidemic, it's been very different. So it's, I think, a reasonable assumption to believe that we have pretty large herd immunity. Everything that I've looked at in the last few months, we've been in decline for the last few months in terms of the shape of the epidemic. I'm guessing, and I can only guess on this, that given the fact that there's been mobility from the UK and this country in many diverse ways, we probably have a fair amount of this strain already all over the place. Do remember that all the estimates, and I think pretty much everybody agrees on this, is that the positives that you actually get, the actual fraction is a very small fraction of a very large number. And some people have actually gone to say that we have 90% more than what we actually test positive. So given, I think contact tracing is the right way to do it. Quarantine is the right way to do it. But given the heterogeneity of the country, given that it's a large country, it's going to be difficult to do that. And I think we're at a reasonable place in the epidemic. I hope, and I think your guest on the show concurred with me in saying that the only issue that we've seen right now is actually increased infectiveness or increased transmission. We haven't actually seen increased virulence. So I'm hoping and I'm optimistic, but you can't obviously swear that things are okay. So we should wait and watch. We should do all the sensible things. But there's probably nothing to fear at right now.
All right, let me also, in fact, take this point across, to Dr. Parikh. Dr. Parikh, will we need more facilities? Because yes, while right now we suspended the flights from UK, but we don't know if those who've already come in have this variant and if it's spread further.
Well, thank you for having me on your show. And I substantially concur with what Dr. Krishna has said. There's one difference, though. I'm not even sure if it's a difference. It's just something I'd like to add on to that. And that is, yes, we will need substantially enhanced facilities. And for that, we only need to look back at the past to be able to understand what one might anticipate in future. So 100 years ago, when the influenza pandemic hit the world, decimating about 100 million people, that's the equivalent of 425 million people today, the second wave, which followed a few weeks after the first wave, was substantially larger. And in fact, it caused far more havoc than the first wave. And then again, there was a third wave, which was not as large as the first or the second waves. So yes, I concur with Dr. Krishna. If we look at this wave, it is ebbing, it is on its decline. But if we see another pattern, which is mutant strains which are coming up with greater infectivity, then one cannot rule out the possibility of a second wave, which could theoretically at least be far more intense than the first. And therefore, we have to be prepared with better facilities.
Okay, I just want to also tell our viewers that there are 5 different aspects that I want to address today. And one was, of course, why these new variants are more contagious and more dangerous. The second one, if we need to change our policy to tackle new variants. That's what we've discussed so far. I also want to then, talk about, do we need stricter scanning of all the foreign returnees? Because now today, for example, in some of the states like Maharashtra, they've said that not just the UK returnees, but also South Africa and Middle East and rest of Europe are going to be tested. They will all be tested and put in a facility until those results come out, and they'll be tracked very closely. Even if you test negative, if you've come from any of these places, you will have to quarantine yourself. Dr. Parikh, shouldn't that be a larger rule across the country right now? Because there is so much of travel, again, already happening in the world. Should we restrict ourselves just to United Kingdom?
I think that's a rhetorical question, and you're quite right in what you're implying. We should not just restrict ourselves to the United Kingdom. Again, keep in mind that the United Kingdom was forthright in detecting the mutant virus and in reporting it. Unfortunately, as a result of that, they have been saddled with the name of the UK mutant or whatever you call it. In fact, it was present in other countries, including South Africa, before it was detected in the UK. And therefore, it is highly probable that the strain is in other countries as well. And in fact, that seems to be increasingly emergent, that the strain is elsewhere. So, to give ourselves a false sense of security because of this kind of labeling that the UK is the culprit, we should actually be grateful to them for being so transparent and proactive in dealing with this. And of course, we have to be cautious with other countries as well, and not just single out one nation for discrimination.
Yes, well, the joke there amongst many, is that, well, they were hoping for a Brexit, but perhaps not this kind where they've been isolated from the entire world. Even China has gone ahead and suspended the flights coming in from United Kingdom. That's how tables seem to have turned on UK right now. But Professor Krishna, if I could come to you on the aspect of how we should deal with it. Of course, it's also that we're seeing a lot of governments bringing in tougher norms. A lot of states bringing tougher norms right now because it's festival season, it's holiday season, and people had begun to come out and socialize and go to clubs and bars. But until we know more about these variants, what would your advice be?
So I'll just touch on two things. What Dr. Parikh just mentioned, I agree with him about the second wave. We should be cautious. I've looked at the influenza data of the 100 years ago several times and trying to figure out whether the same thing is happening here. The optimistic scenario is that we've had multiple small micro surges and multiple small second waves, which is buried in this large plateau. But I would be the first to agree that's a sort of one way of looking at it, and there might be a second larger wave from a national perspective. The other point that Dr. Parikh talked about in terms of surveillance and contact tracing and so on, I really don't have a good feel for how it's been done. So I'll maybe reserve my comments when you come up to the vaccine discussion a little later on and let Dr. Parikh and others take you through the contact tracing and surveillance issues.
Yes, Dr. Parikh, would you like to add to this if it should change our policy right away because we don't know enough about these variants or others which may be out there already?
Well, we do not have too many options to choose from in terms of changing our policy. But what we do have a choice on is to enhance the number of tests that we are doing. Enhance perhaps is a euphemism. We need to increase it dramatically. We are doing well on the testing front. Tanvi, as you're well aware, when we wrote our book in March, we emphasized the need for testing. And although our testing has been stepped up, it still needs to be increased considerably. But more than that, it's the simple things that matter. I mean, we first have to focus on the basics. And once we have done that, we can think of changing strategy. So the old mantra of using masks, of maintaining distance, of washing hands, I think Professor Krishna will agree with me that if this had been carried out as rigorously as it ought to have right from day one, perhaps we wouldn't be in the situation that we are today.
I tend to agree with both of you on that aspect as well. But let's move on to the second, big theme, which also brings me to our next big question. Bharat Biotech today came out and said that this basis their, findings from round 2, they have observed that their vaccine, which is the Covaxin, may offer protection for about 6 to 12 months. And they haven't noticed any side effects in phase 1 or phase 2 so far. Of course, a lot really depends on what they find once they finish their phase 3 trials. But the vaccine has been well tolerated in those groups, at least in phase 1 and phase 2. But I found this part very interesting. Professor Krishna, and we've repeatedly tried to highlight this to our viewers as well, we don't know for how long any of these vaccines may be able to protect us, but 6 months to 1 year, what's your view on that?
So let me just run through some of the issues we've talked about on your show in terms of vaccines before. The first thing about the Bharat Biotech and their collaborators is they've gone about things in a very ordered manner. They made an inactivated vaccine prep, they went through animal trials, they did animal challenge studies, and now they're in sort of phase 1 and phase 2 trials. So there's a very clear systematic order. I've always been very pro the inactivated vaccines and the nucleic acid delivery systems for 2 reasons. With the inactivated vaccines, you have no negatives. When you package your single spike protein and a heterologous protein, any other virus, which is arbitrary virus, then you have all the negatives in the sense that you have an immune response generated against that. So you clearly don't have that. With this inactivated virus, you have the entire set of proteins which are immunogenic. Remember that while people are focusing on the spike protein, it's actually a bunch of proteins which is immunogenic. So the advantage of that is your short-term responses, your long-term responses could be attributed to diversity. If I can get a little bit technical out here, T cell recognition actually occurs with genetic diversity. It's an MHC-based phenomenon. So you will probably also amplify your herd immunity by using inactivated virus vaccines. So this does not surprise me. I am not familiar with manufacturing on large scale, but India has had a track record of manufacturing. So the companies will have to tell you what is their manufacturing plans. But all in all, I think there's a logical progression. There are no serious adverse effects. The immune response is positive. I must say that they have not conducted efficacy trials as yet. The data that I looked at today, they generate neutralizing antibodies, they generate T cell responses, they show evidence of memory, but they haven't formally looked at viral transmission dynamics. The neutralizing antibody tests are done independent. That means they're done in the lab against the virus. That's about, I think, what I have to say for now. And then as the questions evolve, we can take it further.
So you're saying that they will also perhaps have more clarity after the next round of trials to see for how long does the vaccine have an impact?
I think all the trends are positive, but until you have the data, you cannot say. I think they've done it for 3 months right now. If day 104, I think, when I was looking at the paper this evening, if I have it right, but I mean, I could have that wrong. But whatever it is, the durability right now is reasonable. There's another advantage that they're peaking, their antibodies peak a little later. Some of the other vaccines actually peak much earlier. So if you're actually looking at the question of longevity, in a sense, something which peaks later is a good thing because, it's going to last longer. So all in all, I think there are very good things to say about it. But we should wait for efficacy trials. And I think they're going about things in a very organized manner and full marks to them. They need to scale. The numbers are about, I think they did the trial in about 400 participants with 2 groups, one placebo and one this. And the numbers are very reasonable. They get about 90% seropositivity. But again, they need to scale that. And I think they're aware of that.
Yes. In fact, we had a conversation with, the official in charge of one of the regions, and he was telling us of how they're also finding it a little difficult to get volunteers because the minute people find out that there is only a 50% chance that you will get the vaccine and 50% chance that you will get the placebo, they suddenly lose interest and they don't want to go ahead with this anymore. So they did admit that there was a bit of a challenge, but that was in one part of the country and not on an overall nationwide basis. But Dr. Parikh, many would say that 6 months to 1 year is perhaps not a long enough time in terms of protection. Does that effectively mean that you have to get this vaccine every year?
Not necessarily. This is hypothetical, Tanvi. We must understand that we're so early into the vaccine game that we can make a few conjectures and only time will prove us right or wrong. But I entirely agree with Professor Krishna. I'm thoroughly enjoying this discussion. And while I started by thanking you for having me on the show, I must thank you for having him as well. This almost looks like we rehearsed it, but trust me, we've never met each other and I'm seeing him for the first time. But I think the way this discussion is going, we are adding on to what the other is saying. And while he's absolutely right in everything that he said, there is a minor drawback. And just for being technically comprehensive, we must cover it. The inactivated virus, while it has all the great qualities that Professor Krishna enumerated, it's also time-tested. It's solid. It's like the good old Ambassador car, which has been around forever. Sadly, not anymore, though. And, one disadvantage is that if there is an error anywhere at any process during the inactivation, then the results can be catastrophic. This has happened before with the polio vaccine. So the technology harks back literally to the 60s. And in a batch of the polio vaccine, the inactivated vaccine, it was seen that it was not inactivated completely. There were hundreds deaths, thousands, not hundreds. I think there may have been less than 100 deaths, but there were thousands affected. And it was all due to one error. So the room for error is large in the inactivated viruses. And then again, they're not that flexible in incorporating changes rapidly as when a new mutant strain appears.
Okay, so you're saying that effectively we should wait and watch, and I think that would be, and this is a question either of you can take, that would be valid for most of the vaccines that are out there right now, even the ones that have got approvals and are already being used in United Kingdom and elsewhere?
How do you mean
So I
wait
agree
and
with
watch?
Dr.
Yes,
Go ahead.
Professor
Yeah,
Krishna
so
first. Yeah.
Yeah, sorry. I agree with Dr. Parikh about I've gone and studied the whole polio virus story, and that's absolutely right. We should continue to be very careful.
Yeah.
In fact, if he wants a technical point, I can tell him one thing which is not so good about inactivated vaccines, and that is they don't generate CTL responses. Because for
Correct.
CTL responses, you actually need viral replication. So they're not perfect. I mean, I think an ideal vaccine would be a replicating vaccine which has, but you can't bridge the inactivation replication gap, and so you trade off replication for an inactivated vaccine where you get T cell help but not CTL recognition. So I think, yeah, I think the, I mean, my concern really is that one should think about this vaccine in terms of the cross reactivity it generates, and I'd like to get Dr. Parikh to comment on this too. I think he'd agree with me that there's been a lot of viral cross reactivity in our populations. So, the BCG story is probably the one, it's not a virus, it's a pathogen, but the BCG story has got the most attention. But I suspect there's been a lot of cross reactivity across the virome. And I think that this vaccine, too, when you introduce it into the population, will generate a certain level of cross reactivity, will changes in infection transmission dynamics. It's a little hard to say. I think there are no negatives, but how durable it is, time will tell. I mean, it's
Absolutely.
hard to predict.
And that goes, like I asked for Professor Krishna, all of the vaccines which are currently out there, right? That it's only time will tell what are their long-term impacts, and to what extent are they able to protect us.
Remember
Well,
that
Tanvi,
if
your
you look
first
at,
question.
go ahead.
Please go ahead. Please go ahead. No,
No,
go
I
ahead.
think that
It's a corollary to what you asked you.
if you look at the vaccine trials which were done over 30, 40 years, 1 year is a very quick time to actually generate data of this kind. Most of those vaccine trials were developed over 20, 30 years. But yes, we respond soon. So there's only so much that you're going to be able to answer in this time frame.
Yes, absolutely. Dr. Parikh, would you like to add to that?
No, that's exactly what I was about to say.
Okay.
So it's, he said exactly what I would have said. But, your earlier question, should we wait and watch? I was trying to kind of get a hold on that question. If it means, should we wait and watch to look at how long the immunity will last? Absolutely. If you meant, should we wait and watch to take the vaccines? I don't think so. I think there is enough compelling data out, at least with the vaccines that have been approved and rolled out, to take those vaccines. So the wait and watch would be for understanding certain other things regarding the dynamics of this vaccine. And I was about to say exactly what Professor Krishna said.
So effectively, and this is what I understand from the conversations we've been having, that the data that is available for any vaccine right now that has got an approval or is a candidate in the pipeline to get an approval, is there isn't too much of a downside. There isn't too much of a negative effect. How much is the protection? To what extent are they able to protect us, and for how long, we don't know. So there is no harm in taking it right now, but we will have to track it to see what's the response. Now, for how long will we have to track it then? Dr. Parikh, maybe you can begin on that, because obviously we are starting off with the health priority groups. But for how long will the government and the agencies have to track how these people have reacted to the vaccines?
Oh, well, I don't mean this in a flippant way, but they'll have to track it forever. Because once the vaccine is out, it's in the real world. Tanvi, there's one distinction that we should make, and that is between efficacy and effectiveness.
Yes.
Efficacy is what we see in very rigidly controlled clinical trials, typically in hospital settings, occasionally outpatient. But effectiveness is what we see in the real world, where unpredictable variables come into play. And one of them, of course, Professor Krishna alluded to, that is cross-reactivity. And so how effective they will be, we'll only know over a long period of time. These are the post-marketing surveillance. Suffice it to just put in a word of caution. I mean, no Shakespearean play, this would have been an aside. But, the dengue vaccine went through all the efficacy trials and was about to be rolled out in 2017. And when they found that it actually enhanced the entry of another virus and was actually quite dangerous. So I think we're going to need to look at this forever.
I understand that the point that you're making, but I'm assuming it's not practical or it's not done anywhere in the world. Is it, Dr. Parikh?
No, it's done everywhere. I mean, so I think we have a slight misunderstanding, or perhaps I haven't communicated appropriately. When I say study forever, it is gather data forever.
Correct.
I do not mean that we have to wait forever to take the vaccine. You can take the vaccine tomorrow if it's available.
No, of course. No, I'm saying that, once we start, so let's say this. Once we start in the month of January or February or March, we start vaccinating people, and then we step it up gradually and say it takes us about a couple of years to get the first round out to a majority of people in our country, if not everybody else. For how long will we have to track how people are responding to it and whether the antibodies are still working or if there are any other long-term impact?
Well, for a very long time, Tanvi, because, hopefully the immunity might last much longer than the 6 to 12 months that is hypothesized right now. On the other hand, it could be less. I hope it's not the latter. So the flu vaccine, for example, it's a waiting predictive game. Every year, a new vaccine has to be given, and they kind of predict what the mutation is likely to be. Most of the time, they get it right. Now and then, they get it wrong. So we will have to study this, for a long, long time. It's a very dynamic and evolving science, and we are always 2 steps behind the virus. So it's going to be a study that we're going to be involved in for a long, long time.
Okay, Professor Krishna? Yes, go ahead, please.
Can I just come in on the effectiveness versus efficacy issue? It's a very good point. But remember that if you want a positive spin on it, your effectiveness could be more than your efficacy because of herd immunity.
Absolutely. Yes, absolutely.
It's not necessary that when you use those terms, they'll be negative. I suspect that you'll get a hell of a lot of herd immunity out there. In terms of the vaccine, again, I'd like to just qualify a little bit what Dr. Parikh said. There's the outcomes for the individual and there's the outcomes for the community. So if you're looking at immunity at the level of the individual, you can track it. And is this person still immune? And what is the transmission dynamics at the level of the community? I think the answer right now is we just don't know. But I mean, let's be positive. I think the flu vaccine, flu is actually a somewhat unusual case, even though it's an RNA virus. There are not that many viruses which have mutated with this level of seasonal frequency as flu. The dengue example is a tricky example. Again, the the ADE, which he talked about, which is antibody-dependent enhancement, is unusual to dengue. So both those examples are spot on, both flu and dengue, but they are unusual viruses, or they're unusual interactions in terms of viruses.
Okay, the other aspect, and this is because there have been multiple reports that have come in the last 1 month in various newspapers and has been reported elsewhere, is that the government is exploring various options of, as they approve more vaccines, and not just the first one, but as they approve multiple vaccines in the coming months, is there a possibility that you just make the vaccine available in the open market? So while the government perhaps only targets the vulnerable groups and perhaps the poor section to make it available to them, is this a good idea to have the vaccine available in the open market? And how quickly will we be able to do that, considering that while some have started manufacturing, others haven't? Professor Krishna?
So I don't have a philosophical problem with that, but I'm not I'm a lab person, so I don't know how the vaccine regulatory space and how the vaccine market space operates. But I don't have a philosophical problem with that at all. I mean, if international travelers require vaccines and they want to take private vaccines, it's fine with me. But as I said, I'm not a regulatory person, so I can't comment on that.
So will we be able to have those many doses available that you target your priority groups while you can put it out in the open market for anybody who can afford it, say, in the next 4 months?
I would imagine.
Well, there's a free market.
Yeah, Dr. Parikh.
No, go ahead.
Okay, so there's a plethora of vaccine candidates, and I imagine in due time the vaccines will be freely available. But then again, as Professor Krishna pointed out, there are limitations to the inputs we can offer. Policy decisions have other variables other than science which affect it, and I don't mean this critically. There is economics, there's optics, there's a lot of other things. And so we don't know what the government will do. I don't even know what they should do. Basically, yes, people should be able to avail of the vaccine when they want it, because the dynamics change so rapidly. Somebody who's not in a high priority group today could fall in that priority group tomorrow. As simple a thing as a birthday, okay, could go into another group when the person turns 65. But more than that, if the person has elders in the family, so all these dynamics are changing. All I can suggest is we have to have a very flexible policy.
Well, that's as far as, all my questions are concerned, the 5 big ones that we had, listed out at the beginning. And thank you so much for patiently answering all of the questions that we had. Of course, there'll be many more as we move along, find out more about this virus, find out more about how it's impacting people across the world and what we need to do next. But thank you so much, Dr. Parikh and Professor Krishna, for joining us on this conversation. So there you heard it. Yes, in United Kingdom, there's a lot of concern right now because they've come out and immediately announced that they have detected a second new variant of the COVID, which they feel is a lot more contagious and is spreading faster than the initial one. And this one, they suspect, has come from South Africa. And if your viewers will remember, even on the first day, when we were talking about the first new variant that UK had announced and detected, we told you that in South Africa also there has been a separate variant that's been detected, which is supposed to be more dangerous than the current one. Is it more fatal? We don't know. Does it have a bigger impact on your body if you contract this variant? We don't know. That research is still on, but it definitely does spread faster. It's easier to transmit, to latch on to the cells in your body, which is why right now all the governments are on high alert and are coming up with restrictions and rules. And keeping in mind that this is festival season, holiday season, so many people had travel plans, it becomes even more imperative that those who are traveling are at least tracked properly, and there is strict surveillance and strict isolation in cases that it is needed. That is the need of the hour. We should now learn from our experiences in the month of March and how whatever mistakes we made then, we should ensure that we don't make those mistakes now. We can't be having instances where people have just run away from the airport without leaving a trace behind, and the authorities are now trying to chase them and figure out how they have gone home. We can't have a situation where people who've landed here in the last week, 10 days, are not reachable, and their contact numbers and details are not reachable, because we need to know, in case there are carriers of this variant that spreads faster. For a country like ours, it becomes even more tricky and even more dangerous because of the high population and the density that we have. So we have to be on our toes, which also means that there is merit to what the governments are doing when they say that at least in the night, don't step out. Let there be a night curfew, minimize your socializing for now, get back to your homes and celebrate with your family back home. Thank you so much for joining us.